Yeah, good evening to all. On behalf of the Annie Patient Safety Fellowship Program, SAFE program, that is Safety Awareness for Excellence, we welcome you all to this presentation. This is a monthly learning session which is done by the Annie Patient Safety Fellows. So before we begin the session, let's all rise up for this Annie anthem as a mark of respect, after which we will be beginning our session. May I request all to kindly rise up. You can close your videos if you want. Thank you.
We are the voice, the hands that care, guardians of hope, always there. With wisdom and courage, we stand tall, answering the call, serving all. In every moment, through joy and strife, we lead with purpose, we honor life, building the future with knowledge and grace, transforming healthcare in every space. Passion to action, our guiding light. For every life, we fight the fight, upholding safety with hearts so true. We are ANEI, proud in all we do. Together we rise, united we lead, planting the seeds for a brighter tomorrow. Together we rise, united we lead, planting the seeds for a brighter tomorrow. ANEI, nurses make the difference to humanity, shaping the future with strength and unity. Passion to action, our guiding light. For every life, we fight the fight, upholding safety with hearts so true. We are ANEI, proud in all we do. We are ANEI, proud in all we do.
Just move the slide forward, Dr.
Yeah, this webinar is brought to you by the Annie Patient Safety Fellows. This program is conducted by Annie from the Patient Safety Movement Foundation, which is from the USA. And the topic is chosen from the culture of safety, patient safety movement, which is Dr. Michael Ramsey is the one who has approved, and Annie conducts this fellowship program. And every year we have candidates who are getting admitted to this program. It is purely an online, and they do projects at their own workplaces. So this year we have 12 candidates who have registered, and they do a monthly program to update themselves. So that is about the fellowship program. And a small announcement about the upcoming flagship, 6th annual flagship event, ANICON 2026, which is conducted on May 29th and 30th at Mumbai. The topic is transformational leadership, powering the future and value of care. So all of you are welcome to attend this. And before the ANICON, we have a couple of events which is taking place. So here in this, you find the QR code. You can scan that and register. The registration closes by 31st of March. Early bird registrations we encourage. So again, I'm reminding you, 29th and 30th at Bandra, Mumbai. Registrations are right now open. And we have a couple of events which happens before the ANICON, and you are being awarded during the ANICON 2026. So these projects are, the first one is the improvement project, Nursing Operational Efficiency Challenge, which is purely for people who are working at the service area. And the next one is the nurse-led research competition, which is again for nurses and students who are working at the hospital. And we have the QR code here. Remember, 31st March is the last date for registration. Once you register, you will get the details of how to go about. The next one is the nurse-led innovation competition, which is for nurses and students again. So the next one is Future Nurse Challenge, Engagement Challenge, investing in the next generation of our profession. This is mainly again for youngsters who are working at the clinical area. Kindly encourage them to participate in these competitions. Exclusively for students, we have the elocution competition, which is the extempore, and the topic is from celebrating our profession. So based on this, they can prepare, but on the spot, small topics would be given. The criteria is also here. So please encourage principals, academicians who are here, encourage your students to participate. And another competition, again, elocution extempore for staff nurses, and the theme is zero harm. So again, they have to scan the QR code and do their registration. Reels competition, which is exclusively for nurses and student nurses. This again, the objectives are placed here. Our nurses, our future. Empowered nurses save lives is the theme based on which they have to prepare the reel and send it. The criterias are again placed in the template. We will be sharing it in the Annie group. Remember, Annie members and non-Annie members, there are different registrations. So please encourage more membership so that they can avail that privilege. Then we have a poster presentation competition, again for nurses and student nurses. The theme is powering the future and value of care. Then we have transformational leadership, powering the future and value of care for Annie Young Leaders of Tomorrow Award. So this is for young nurses who are working at your setup, and especially the 4th year BSc nursing students. If they are smart and they are having the good clinical skills, this CNO of the organization along with the principal, you can send these details for their awards. Then the Annie Young Leaders Award for Service and Academics. This is exclusively for service and academic professionals who are already working. For them, again, down we have the apply and nominate, and we have details, so you can send your nominations there. Then we have Annie Trendsetter Award. So the recipient of this award should be a senior level RN, which can be a supervisor or a nurse manager. So this is for the Trendsetter Award. Then we have Annie Best Nurse Leadership Award for Service and Academicians. Right. So these are a couple of programs which is lined up, and the last date is this month we'll have to complete the registration. And once the registration is over, the details would be sent across. So we will again be sharing with the groups. If you have any doubts, you can contact your officials, your chapter officials, chapter heads, or any ANI members. We keep sending these templates to them. Any doubts, please contact us and please participate and encourage more registrations. Right, now we are coming to the ANI Patient Safety Fellowship Program. As I told you, we have this is cohort 5. This is the 5th year of our program, and we have lined up the program for the entire year. January and February we have already completed, and those recordings are available in the YouTube. For those who have missed, you can go back and see that in our ANI YouTube we have. So the month of March, we are going to talk about medication recognition, WHO 2023-24 update, and Chandrani Chakraborty will be doing this. This will be helped by her mentor, who is the previous cohort. Miss Varnalata will be doing the session. So the session is taken over by Chandrani, who will be presenting to you with her mentor, who's Varnalata. A small note about Miss Varnalata Patro, who's the principal of Aryavad Ancient Academy Nursing. And she has got about 17 years of experience, and she is the previous cohort 4, and she is mentoring Chandrani Chakraborty. A few lines about Chandrani is she works with Apollo, who's got rich years of experience, 30 years of experience at Apollo Multi-Speciality Hospital at Kolkata. So today she will be presenting to you. I hand over the session to Ms. Varnalata to take it over. Happy to see so many people come in. So kindly keep yourself muted. If you have any questions, you can send it in the chat box. We will be answering all your queries at the end of the session. Over to Swarnalata.
Thank you so much, ma'am. I request to Chandrani to share the slides.
And sorry, next month we'll be having, in the month of April, on IV medication safety, infusion error prevention by Miss Nagarani, who is also a fellowship person. You can share your slide now.
Thank you so much, ma'am, for your kind introduction. And today we are really happy to have a part of this safe session. And I would like to extend my heartfelt gratitude to our chief mentor, Madam Thankam Gomez, who has continuously supporting us and guiding us throughout. And I would like to extend my heartfelt gratitude to all the distinguished members of ANI. And your leadership continues to inspire us to excellence. Today, I would like to address the critical practice of medication reconciliation. And this session is going to take over by my colleague from the cohort 5. She is Ms. Chandrani Chakraborty. She is going to talk about the medication reconciliation in details. Next slide, Chandrani. Next slide. Yes. The medication reconciliation is the process of creating the most accurate list possible of all the medications a patient talking, that is including the patient name, doses, frequency, and route, and comparing it against the physician's order at transition of care, that is your admission, transfer, and discharge. This systemic approach minimizing the errors, preventing the adverse drug events, and enhance the patient safety. So look at this slide. This diagram is showing that the drug reactions, drug-related problems are used, and there is a drug-related problems are mainly causing because of many factors. You can see there are the multi-factors are contributing these drug-related factors, the problems. I would like to ask the audience, anyone can tell me, these DRPs are the multifactorials or not? Any one of you can explain about these drug-related problems and the medication reconciliations. These are the co-related or not, and how one factor or the multifactors are contributing this DRP or not. Yes, I can see in the chat box that yes, the DRP, the drug reaction problems are multifactorial, and we can see these are the 4 domains are there, the 4 the factors which is contributing towards the drug relation problems. If you look about this age-related problems, one of the older adult can have a cognitive declines, have complicated regimens towards the medications, and the patient who is elderly, they can have a anxiety and poor adherence towards the medication process, which mainly causing this these drug related problems. And through this medication reconciliation process, it is helping to prevent these DRPs by correlating towards the right timing for communication. So it is how it is communicating, it is coordinating with the medication reconciliation and the DRP. If you look about these patient factors, sorry, the last slide. Last slide. Yeah, the patient factors, we can see the patient have the lack of knowledge, lack of motivations, intolerance towards the medication, and the financial barriers. These are the main factors towards the DRP, and we can do by adhering this medication reconciliation by finding these actual barriers, and we can resolve it. So in this process, we can reduce the DRPs. If you go to the medication process, some specific medications are inherently they are risky, and the overprescriptions, polypharmacy, and the adverse drug events, they are contributing towards the medication factors towards the drug related problems. So as a multidisciplinary professionals, the doctors, nurses, and the pharmacists, if they were collaboratively, they can work on this medication process, then the drug related problems can be resolved, and by adhering this medication reconciliation process. If we'll go to the system the system factors, there is a missing doses, missing informations, conflicting information, confusing information can cause to the duplication of the prescription. It leads to the drug related prescription, drug related problems, and the medication errors will be high. So what we can do it, we can do the critical when we are going to review the medical records, we have to very careful and we have to detailing while the patient is going to discharge. So these are the factors we have to think about before going to review the medications of the patient. And we need to ask ourselves, have I considered all these 4 domains? So this is how we can move from the reactive to proactive care. So next slide. Coming to the medication reconciliation in action, if you'll see the medication errors are a leading cause of a patient harm worldwide. Medication reconciliation is only one key who is recommending by the WHO for a safe practice of medications. So focusing on this WHO 2023-24 updates and is the practical applications, we can ensure the accurate medications at every transaction of care. So this medication list is not only the checklist, it is a collaboratively, it is a patient safety actions. So you can see this picture when a patient is coming from the home to the hospital, and during the hospitalization, the patient can transfer from ICU to ward again, the patient can go to the home. So these are the different transactions of care. We have to be very careful as a healthcare professionals, as a doctor, as a nurses, as a pharmacist, we have to reconcile the medication the patient is getting so that we can prevent the errors. Next slide, please. Yeah, so today we can get the objective, the session objectives will be understand throughout this session, we can get to know that we can understand the medication reconciliation and its importance. We will get to know the WHO recommendations about the patient safety as well as the medication reconciliation processes, and we can identify the different roles of the healthcare professions in reconciliations. Like we can standardize the different roles of the doctors, nurses, and the pharmacists in the reconciliation process. So by adhering this SOP in our system, we can minimize the medication errors. And we can also focus on the best practices to improve the patient safety. So you can see this picture, there is 2 columns are there. One is home and pre-admission medication the patient is getting, and one is the hospital and the discharge medication. That means what? The patient is coming from the home, admitting into the hospital, taking the medications. During admission, we have to reconcile all the medication the patient is getting at home. Then if the patient is admitted in the hospital and transferring from one unit to another, again, we have to reconcile all the medication the patient is getting. And while during the discharge time, this is again important aspect and important point to identify, to verify all the medications the patient is going to get it, and we have to do a checklist whether we have all the discrepancies at the same time. We need to correct it. This is how we can prevent the harm. Next, we can go to the one video that is by WHO. So we can play this video. We can know the medication no harm. Chandrani voice should be there.
Is there a voice behind? Audio is not there.
Yes, this is the video. I think there is a voice is not there. Audio is not there, Chandrani.
No, audio is not there, ma'am.
Okay. So, ma'am, this is a small video. It's available in the YouTube also regarding this WHO updates on medication prevention and medication reconciliation. The updates from 2023 and 24. You can see the YouTube also. You can get all the details of this WHO recommendations. And now I would like to hand over to Chandrani, who is the patient safety fellow of cohort 5. And already madam has explained about her and she is introduced. She is now working as an assistant nursing superintendent at Apollo Multispeciality Hospital, Kolkata. And she has 30 years of immense experience in the critical care. And she is a master and she is a master in medication reconciliation process, as well as she is involving directly because on day-to-day life, she is facing with all these medication errors problems, and she is taking is one of the QIP process. So over to you, Chandrani.
Thank you, ma'am. Good evening, all. I feel deeply honored to be a part of this journey, which is shaping the future of patient safety through collaboration and learning. And at the beginning, I extend my heartfelt gratitude to Annie for giving me this wonderful platform to learn, share, and grow. A special thank you to Ma'am Thankam Gomez for her constant encouragement and to my mentor, Madam Sharnalata Patro, whose guidance has supported me throughout this fellowship. I am equally indebted to Dr. Michael Ramsey, CEO of Patient Safety Movement Foundation, whose vision and leadership continue to advance the cause of safer healthcare worldwide. I would also like to acknowledge Madam Madhukari Roy, Director of Nursing Eastern Region, Apollo Multispeciality Hospital, for her constant support and guidance. My gratitude extends to leadership team of Kolkata Apollo, whose commitment to excellence in healthcare motivates us to strive for higher standards of patient safety. Finally, I would like to thank you all the distinguished leaders and participants attending this session. Your presence enriches this fellowship and motivates us to work collectively toward our shared mission. Together, let us commit ourselves to advancing patient safety and ensuring that our collective effort bring our lasting change. With this, I am starting my session. Now I will discuss what medication reconciliation is. The key definition according to WHO SOP 2023 to 24, it is a formal process of creating most accurate list of medication, including prescription medication, including herbals, vitamins, nutrition supplements, over-the-counter drugs, vaccine, diagnostic and contraceptives, radioactive medications, parenteral nutrition, blood derivatives, intravenous solution, all medication, all things patients are previously patient got. Details include dose, route, frequency, and purpose. Goal is to ensure continuity of care during transition, admission, transfer, and discharge. Now, why it matters? Patient safety. First and foremost, medication reconciliation protects patient from adverse drug events. Things like overdoses, missed dose, and harmful drug interaction. By carefully checking and updating medication list, we reduce the risk of harm. Think of it as a safety net that catches error before it reaches the patient. Continuity of care. Ensure
Chandrani, you are muted. Unmute yourself, Chandrani.
continuity of care. When patients move between settings, say from home to hospital or hospital to rehab, their medication list often changes hands. Reconciliation ensures that the same correct medication follow the patient across the transitions. This consistency prevents gaps in treatment and keeps care seamless. Next, efficiency. Efficiency here means fewer mistakes and smoother workflows. By reconciling medications early, we avoid duplication, unnecessary prescription, or dangerous drug interaction. It saves time for healthcare teams and reduces confusion for patients. Last, trust. Finally, reconciliation builds trust. When patients see their medicines are reviewed, explained, and documented, they feel involved in their own care. This engagement improves adherence. Patients are more likely to take medication correctly when they are understand their plan. Now we will see some medication error related to reconciliation issues. Here we can see the average hospitalized patients is subject to at least one medication error per day. This confirms previous research findings that medication error represent that most common patient safety error. More than 40% medication errors are believed to be result from inadequate reconciliation in handoffs during admission, transfer, and discharges. Of these errors, about 20% believed to result in harm. Many of these errors would be averted if medication reconciliation process were in place. Now we will discuss about WHO 2023-24 focus areas. There are four main priorities focused. Priority 1, stronger focus on high-risk medication. This priority targets medication that carry a higher risk of causing a serious harm if used incorrectly. Key actions: identify high alert drugs like anticoagulants, insulin, opioids. Implement monitoring protocol tailored to these drugs, like when you are giving anticoagulant, check INR. When you are giving insulin, check capillary blood glucose. Like that way, you have to implement some monitoring protocols. Integrate risk alerts into electronic medical records to flag dangerous combination or dosage. Educate patient about side effects, safe usage, and signs of overdose or complication. Goal is to prevent adverse drug events by proactively managing the most dangerous medication. Now coming to priority 2, it is emphasis on transitions of care. It means medication errors often occur when patients move between care settings. This priority ensures smooth handoff. What should you do for safety? Ensure seamless transfer between hospital, primary care, rehab, and home. include complete medication list in discharge summaries, schedule follow-up calls within 24 to 48 hours to verify medication understanding and adherence. Use standardized communication tools like SBAR to reduce miscommunication. After getting discharged from home, we can confirm by calling the patient or patient relative that what medication they are getting at home and how. So we can understand their um, understanding. Goal is to maintain medication accuracy and continuity during every transition. Now coming to priority 3, it is use of digital tools and standardized process. What it means is to leverage technology to make reconciliation faster, smarter, and more consistent. How we do it? Integrate medication health cloud to centralize patient medication data. Apply best possible medication history together to tools together accurate list. Use analytes to detect patient patterns and prevent medication error. Use e-learning platforms for staff training to ensure consistent practice. Goal is to standardize consistent reconciliation across system and to improve safety through digital innovation. Now coming to priority 4. It is about patient and family engagement. It means that patient and families are the active partners in ensuring medication safety. It is done by involve patients in reviewing their medication list, use teach-back methods to confirm understanding. Like after giving instruction, you ask them, can you explain how you will take this medicine? Provide visual aids and health literacy tools to simplify complex regime. Review pill organizer together to ensure correct usage and timing. Goal to empower patient to take ownership their medication safety. Let us know now a crucial aspect of patient safety, high alert medication reconciliation. As you can see on the slide, the message is clear. Reconciliation of high alert medication is not just important, it is essential. There are the drugs most likely to cause serious harm if used incorrectly. So ensuring accuracy at every step matters the most. This slide highlights why we must place stronger emphasis on high-risk medication. These are the drugs that can cause serious harm if error occurs. So our vigilance is critical. First, they carry danger of devastating error because many of these medicines have a very narrow therapeutic range. Even a small mistake in dosage can lead a major adverse event. Second, they often involve vulnerable patients. These are critical care with kidney problems or multiple medications. These groups are especially at risk. So reconciliation become more important. Third point, during transitions of care, such as admission, transfer, or discharge, there is a high chance of medication being omitted, duplicated, or dosed incorrectly. Reconciliation ensures continuity and accuracy at these crucial points. Finally, focusing on these drugs helps us reduce adverse drug events by targeting high-risk agents. We directly support the goal of preventing avoidable harm and improving patient safety. Common examples including insulins, warfarin, antiplatelet agents, opioids, and potassium chloride. Each of these requires careful monitoring and precise communication among the healthcare team. High-risk medications demand our strongest attention, and reconciliation is the safeguard that protects patient from preventable harm. Now coming to transition of care. We are second priority of WHO in medication reconciliation is transition of care. This slide illustrates the patient's journey through the hospital from admission to discharge and shows how medication reconciliation safeguards in every steps. It begins with admission from home, where we collect patient's medication history. Then next step is verification, cross-checking that history against reliable sources to ensure accuracy. During hospital stay, medication often change. That's why reconciliation at admission and again at discharge is vital. So nothing is missed, duplicated, or incorrectly prescribed. Before discharge, communication and patient engagement are emphasized. This ensures patients understand their medicine and can continue them safely at home. Finally, the transition back to home complete the cycle. Each stage, admission, verification, reconciliation, and communication in discharge, works together to prevent error, to protect patient. The key message is simple. Safe transition of care depend on accurate medication reconciliation and clear communication. Now we have seen how many medication reconciliation fits into each stage of a patient hospital journey. Let me ask you this: in your own practice, which stage do you feel carries the greatest risk of medication errors? Admission, during hospital stay, or at discharge? And why? You can share in chat box. Many error occurs at right at admission. Patients often arrive in incomplete or inaccurate medication histories, and if we don't verify carefully, mistakes can carry through the entire hospital stay. For example, a missing antihypertensive or duplicated antibiotic can cause the serious harm. That's why reconciliation at admission so critical. It sets the foundation for safe care throughout the patient's journey. Another vulnerable point is during hospital stay itself. Medication are frequently adjusted, dose changed, new drugs added, some stop. If these changes are not documented and communicated clearly, confusion builds up by time of discharge. Reconciliation during hospitalization ensure that every adjustment is tracked, preventing omission or duplication later. Now we will
Chandrani, in the chat box, many of has answered regarding this your question. That is about admission. Somebody has written discharge. Most of the members, they have written admission is the crucial time for medication reconciliation.
Yes, admission. I have already explained that one. Admission is the right time to reconcile the medication, because if the proper medication reconciliation is not done in hospital admission, then throughout the hospital, say patient journey will not safe. It is also admission time is also important, and during hospital transfer time, if any medicine has been omitted or dose changed, that also is important, because if it is not done correctly, so overdoses or missed doses can occur. Both the things are same important. Now we will discuss medication error during transition of examples of medication error during transition of care. Here we can see the medication omissions most common 41%. A patient admitted from home has their chronic blood pressure medication or insulin forgotten in the new patient orders, leading to uncontrolled condition. Is it happening? Next, failure to discontinue medication. A patient is discharged from home, it is about 24%. A patient is discharged from hospital but continues taking temporary medication. Patient is advised for antibiotic for 5 days in hospital, it is continued in discharge summary, or sedative, it is continued in the discharge summary. So indented this leading to potential toxicity. Incorrect dosage or frequency, this is 16%. A patient discharged with prescription written for daily instead of weekly for medication like methotrexate, causing severe harm, potentially overdose. This methotrexate can cause the gastrointestinal damage, hepatotoxicity, bone marrow depletion, can causes hospital readmission. Allergen exposure, an allergy documented in community setting is not transferred to hospital chart, leading to an administration of a medication that can cause allergy. Wrong drug patient medication or transcription error. Sometimes it may happen a patient medication list improperly copied from a nutrition nursing facility to a hospital, resulting in patient receiving amiodarone instead of amlodipine because of wrong transcription. Both are the totally different effect. They have totally different effect. One is for hypertension, antihypertensive, and one is for antiarrhythmic. The patient will suffer a lot. Incorrect route of administration. Sometimes oral tablet can mistaken as IV, or vice versa, IV as oral. That can cause the inappropriate medication effect. Incorrect therapeutic interchange. On admission, a patient brand name medication is switched to a generic equivalent to different absorption rates. That is patient will get under treatment. The key lesson is that each of these errors is preventable. They arise from gaps of communication, documentation, or reconciliation. By being meticulous at every transition, admission, transfer, and discharge, we can protect the patient from serious harm. Now, third priority is use of digital tools and standardized process. This slide emphasizes how global initiatives, especially from World Health Organization, are tackling medication errors through digital tools and standardized process. The focus on medication reconciliation, checking and confirming medication at admission, transfer, and discharge. This approach is part of WHO Medication Without Harm Global Patient Safety Challenge, which has a bold goal to reduce severe avoidable medication-related harm by 50%. That's huge impact on patient safety worldwide. The evidence shows that when hospitals adopt digital solution like electronic medication records, automated alerts, and standardized reconciliation form, they can cut the unintentional discrepancies by up to 45%. That means fewer omission, fewer duplication, and safer transition of care. Technology and standardization are not just supportive tools, they are essential safeguards. By combining them with clinical vigilance, we can make medication reconciliation more reliable and protect patients from preventable harm. Here we can see a standardized form designed to make medication reconciliation more reliable and consistent. Let's break down its key section. First is patient information. Here, basic identifiers, IPSG1, like name, date of birth, and patient ID, ensure accuracy and avoid mix-ups. Next, community pharmacy details. Capturing the pharmacy name and contact number helps to verify prescriptions and clarify doubts. Next, medication management. Notes whether medication are self-administered, given by a caregiver, or otherwise. Patient records any allergic or specific reaction. Now, sources of information. This portion has multiple options like patient interview, caregiver input, from where you are getting the information. Pharmacy records, blister packs, EHR, EMR, and more. This ensure we build the best possible medication history from reliable sources. Now coming to BPMH table. Here we document each medication, name, dose, route, frequency, indication, prescriber, and note any discrepancies. Importantly, there is space for a resolution plan and action. So error don't just get identified, they get corrected also. Now, at the completion details, the form ends with the name and date of person completing it, ensuring accountability. This standardized form reduces variability that they guide clinician to collect complete, accurate information, and studies shows that they significantly cut down medication discrepancies. In practice, this means fewer omission, fewer duplication, and safer transition of care. This slide highlights 4 major benefits of using digital tools in medication reconciliation and patient care. First, improved accuracy. Electronic system can pull medication histories from multiple sources like EHR, pharmacies, and patient records. This reduces reliance on patient memory and ensures we capture the best possible medication history. Second, efficiency and speed. It has been seen that digital system can save on average over 6 minutes per patient compared to manual or paper-based reconciliation. That means clinician can spend more time on direct patient care. Third, clinical decision support. Digital platform can instantly alert us to drug interaction, allergies, or contraindications. This proactive safety net helps to prevent errors before they reach the patient. Finally, support for telepath. During crises like COVID-19, digital tools facilitate safe, remote, or virtual medication review. These digital tools don't just make reconciliation easier, they make it safer, faster, and more adaptable to modern healthcare needs. Now coming to importance of standardized process. First, they reduce variability. Without a standard, everyone collects medication history differently, which leads to mistakes. Second, they create accountability. Clear roles for doctors, nurses, and pharmacists means fewer errors and better teamwork. Third, improved compliance. They improve compliance with structured protocols. Hospitals have raised reconciliation rates from as low as 4% to over 90%. Finally, they support continuous improvement. Standardized tools, whether digital or paper, allow us to audit and keep improving quality. This standardization makes medication reconciliation more consistent, safer, and more effective. Now, economic and safety benefit. This slide shows that standardized medication reconciliation not only improves safety but saves the money. By reducing preventable readmission and avoiding costly adverse drug events, hospitals cut expenses in improve patient outcomes. The WHO emphasizes using technology and team-based workflows to make reconciliation reliable and efficient. In summary, WHO focus on integration technology into standardized multidisciplinary workflow to move away from error-prone, ad hoc or manual process, ensuring a reliable, efficient, and accurate transfer of medication information. This slide highlights how family and peer plays a vital role in helping patients stick to their medicine. These give emotion, they provide emotional support, positive encouragement, practical support in monitoring health and with diet and exercise, being a role model for behavior change. It is a resource for knowledge and coping technologies, providing medical information and support patient behavior. The medication adherence is not just about the patient alone. Family and peer involvement strengthens safety, confidence, and long term health outcomes. This slide shows three main steps of medication reconciliation, plus the final step of communication. Here we can see the steps. First, collect. We create a best possible medication history. This means interviewing the patient and family, checking pharmacy records, past discharge summaries, and other reliable sources to build a complete list. Next, compare. We match the current physician orders with the prior list. Here we identify discrepancies such as missing drug, dose changes, or duplication. Then we correct it. As a team, we resolve those discrepancies. We decide what to continue, stop, or adjust, ensuring the final list it is clinically appropriate. Then we communicate finally. We update the records and inform both patient and the healthcare team so everyone is aligned. Reconciliation is a structured process: collect, compare, correct, and communicate. If done well, it prevents error and ensures safe transition of care. We will now discuss reconciliation process. It starts from home, where we gather information from the patient, family, medication files, pharmacy database, or past health records. From these sources, we build the best possible medication history. When the patient is admitted, doctor orders medication for admission and during transfer. At discharge, we prepare the best possible medication discharge plan. This plan includes reconciled prescription. The physician discharge summary is a clear medication schedule for patient. Finally, when the patient returns at home, the discharge plan is communicated to both patient and next provider of care. This is a continuous process: collecting, verifying, and communicating medication information at admission, during hospital stay, and at discharge. If done well, it improves accuracy from less than 50% to over 95%, and ensures safer transition of care. Three simple steps of medication reconciliation. First, we verify the collecting complete list of everything patient takes: prescriptions, prescription medication, vitamins, supplement, any even IV solution. Second, we clarify to make, sorry, I have some throat problem. Second, we clarify to make sure that medicines and doses are appropriate. Finally, we reconcile by documenting any changes and updating the record. The key point is verify, clarify, and reconcile. This ensures accuracy and patient safety. What does it mean by based BPMH? It is about collecting the most complete and accurate medication history that includes not just prescription drugs but also over-the-counter medicine, vitamins, and herbal medicine. The WHO has also emphasized integrated traditional and complementary medicine into safety system because these products can interact with the prescribed drugs. If we fail to include OTC and herbal products, we risk serious errors. A thorough BPMH improves patient safety by making sure all medicines are considered. Impact on patient safety. The 2024 updates highlight that failure to OTC product and supplement in record is a major cause of medication error as they are not considered as medication by many, yet pose high risk. I am giving one example. Painkiller. A 50-year-old patient admitted for stomach ulcer is prescribed strong anti-inflammatory medicine. The team records his prescription drugs but forget to ask about over-the-counter drug. Later, it is discovered that he has been taking ibuprofen for daily for knee pain. That combination worsened his ulcer and leading to bleeding. So, over-the-counter drug is very important. Now, roles and responsibilities of clinical team. Think of medication reconciliation like a team sport. No single player can win the game alone. Everyone has a role to play. Based on WHO aligned guidelines and updated patient safety initiative, such as in the High 5S project and 2023-24 implementation studies, medication reconciliation is defined as a shared interprofessional responsibility. However, specific roles are assigned to maximize accuracy and safety, with a strong emphasis on pharmacist-led process. Everyone has a role to play. Doctor acts as strategists. They review medication list, spot discrepancies, and ensure orders are correct. Nurses are the frontline communicator. They collect medication histories, report issues, and guide patients in updating their medications. Pharmacists are the specialists. They dive deep into the drug review, check for the interaction, and make sure dispensing is accurate. Patient and families are the informants. They provide the most complete list of medication and share concern openly. The key idea is collaboration. When each member fulfills their responsibility, transition of care becomes safer and medication error are prevented. Now we will break down of responsibilities by role. Pharmacists take the leading role. They are the medication experts and coordinators. Their tasks include reviewing, interviewing the patient and families to obtain possible medication history, comparing that history with admission or discharge orders, resolving the discrepancies, counseling the patient about the changes, and giving feedback to them. Physicians are prescribers, take the directory role. They make the clinical decision that makes comparing the collected history with their intended orders, documenting and authorizing any changes, and finalizing the discharge medication list to ensure it is communicated to the next care provider. The key message is pharmacists lead the technical process while physicians direct the clinical decision. Together, they ensure safe and accurate transition of care. Nurses take an operational and coordinational role. They are often first to gather medication information during acute admission. They make sure reconciliation is completed before giving the first dose, and they help patients to understand their discharge medication. Pharmacy technician or students play a support role under guidance of pharmacists. They collect the detailed medication list, the BPMH from the patient and relative. They flag any discrepancies to the pharmacist to review. The key idea is nurses coordinate the safe transition of care, while pharmacy technicians and students support accuracy by collecting detailed data. Together, they strengthen the reconciliation process. And last, patients and carers. They are the main source of information. They keep on updating the accurate list of all medication, including OTC, herbal, any medication. Actively engage with the team during transitions. Medication reconciliation sounds simple, but in practice, it faces many challenges. System issues, poor documentation, and clunky electronic records make the process harder. Human factors, high workload, frequent interruptions, and staff shortage, particularly in the emergency department, lead to missed steps. Communication failure. Inadequate collaboration between pharmacists, nurses, and physicians often results in disconnection between prescribing and patient or poor handovers. Information gaps, difficulty in obtaining accurate medication histories from patient and caregiver. The reconciliation fails not because it's unimportant, but because system, people, and communication break down. Recognizing these challenges help us design better solutions. We have seen the challenges of medication reconciliation. Now let's flip to the coin. How do we improve it? Optimization of technology. Think of cleaning up your messy EHRs, like tidying your desk before starting your work. Digital integration makes records smoother and safer. Staffing and workflow changes. Pharmacist-led reconciliation is like having the expert pilot the plane, while tasks are delegated to the crew for efficiency. Education and training. Refresher training keeps the skills sharp, like updating your phone apps so they run better. Enhancing patient engagement. Patients are not passengers, they are co-pilots. Education reminds and active participation make them part of safety net. Standardized workflows are like traffic rules. Everyone follows the same, reducing accident. Technology, teamwork, training, standardization, and patient partnership. These 5 strategies are safety shield. If we were designing a safety system in your hospital, what would be the first thing you would add? Think of pilots. Before takeoff, their use checklist to avoid missing anything. In healthcare, forms and checklists do the same for the medication. It's an orchestra. Doctors, nurses, pharmacists, and patients are the different instrument. Educate staff regularly, just like athletes. Train daily to stay fit. Healthcare staff need regular training to stay sharp and avoid errors. Next, engage patient. Patients are not passengers. They are co-drivers. Their involvement ensures journey safe. Forms teamwork, training, and patience. 4 service that run safety into action. Imagine medication reconciliation as a stage play. Each professional has a unique role, and together they perform a drama of patient safety. Reveal each role like character. Pharmacist, the wizard of medicine. They hold the spell book of drug knowledge, guiding reconciliation and counseling patient. Doctors, the decision makers. They write the prescription, review the reconciliation, and ensure the magic of treatment is safe. Nurses are the guardians of care. They administer medicines, and educate patients, and protect transition of care like shields of safety. Quality and patient safety team are the overseers. They watch from the above, ensuring the whole performance follow the script for safety and compliance. When pharmacists, doctors, nurses, and safety teams wave their powers together, reconciliation becomes a spell against harm. These references I have taken: WHO Global Patient Safety Action Plan, WHO Medication Safety Transition of Care, WHO 2023-24 Patient Safety Updates, AHRQ Patient Safety Network, March 27 to 2024, Wington and Cohen Medication Reconciliation, whose job is it? Joint Commission Journal on Quality and Patient Safety 2004. Now I will wrap up. With whole the my slides. Medication reconciliation is like a detective work. We collect clues, compare them, and solve discrepancies to protect patients. Step in reconciliation: verify, clarify, and reconcile. 3-step formula: check, confirm, correct. Best possible medication history is the foundation stone. Doctor, nurses, pharmacists, patients. Each player has a position, but pharmacists are the captain of accuracy. Challenges are present as the roadblocks on the journey: system issues, human factors, communication gaps, patient forgetfulness. Improvement strategies are like 5 tools in a toolbox: technology, staffing, training, standardization, standardization of strategies, and patient engagement. As there are four pillars of safety: standardization, teamwork, education, and patient involvement. With this, I am ending my slides. Now,
You can stop sharing, Chandrani.
ma'am, I will share in chat box a questionnaire, MCQ questionnaire. The participants can answer this. Now I am sharing that.
Okay.
Requesting all participants to answer. It is a quick questionnaire. You can complete it within 10 minutes or 10 minutes time. Please do the answer the question.
Chandrani, stop share your screen and come on to the video so that people can answer and see you and appreciate you. Well done. We have exceeded time, participants. Kindly hold on just a couple of minutes. You can post your questions.
Anybody want to share, ask anything? There had been some questions in the chat box that, can we add how many of you are using reconciliation form? Those who are in the audience from hospitals. How many of you are using medication reconciliation form?
Aisha has answered. We are using medication reconciliation form.
Okay.
Apart from that, anybody else?
So are you, Aisha, are you using a self-designed form or something that you have borrowed from WHO? So just for the road before you go, I want to share a story. Before the reconciliation was introduced when I was in Fortis, this was many years ago, not now. A patient gets admitted for surgery, and they have taken the history of the patient. Those time reconciliation was not there. So they took the previous history of the patient, what all medicine patient is taking. Anesthetist came and he stopped the beta blocker for the surgery because he is going for knee replacement. So he stopped the beta blocker. He said, hold beta blocker. Okay. So in the drug chart, it was written hold and that's it. Then patient went to for knee replacement. Patient went to ICU. Patient came back, but nobody noticed that the beta blocker was not restarted. So I actually was on rounds that time, and they suddenly some commotion. Why this patient is having chest pain? And I'm a cardiac nurse, so I have got a lot of experience. So I went to the patient, I started looking at the file, and then I found the beta blocker was not restarted. The beta blocker patient was getting for angina. So it just came back. The angina just came back. So that time we discussed about this. So what happens in reconciliation? I mean, we created a very simple form that at the time of admission you list down all the medicines, and whenever they are changing location, you write all the medicines which are given in their place also, and we use some circling technique to say, okay, this medicine was not added there. So there was somebody watching, and in India we don't have the luxury of having pharmacologists in our hospitals, right? They may not be able to come and do all the reconciliation in the wards. I mean, with the hospitals which are going for JCA, etc., they may have, but otherwise no. So the role of nurses becomes even more important in India. So my specialty nurses used to check their patients, and they used to come and they used to find gaps. So I think we had 4 columns in that time. So that means we are anticipating there will be 3 movement of the patient, and the last one is the discharge one. So you can see all the medicines in one format to see they were taking all this. and this is what happened during the time at the time of discharge. So the doctor can also decide, have all the medicines the patients were on before they came for the hospital is restarted. Like for example, anticoagulants will be stopped for certain patients for surgery, but they need anticoagulants because of some other medical problem that they are having. So you need to restart. But if you don't restart, they will come back to hospital for another problem. Correct? So, fantastic presentation, Chandrani. Lot of knowledge you have packed in. You have just made all the WHO updates. Just
Thank you, ma'am.
put it into all the presentation, and slides were wonderful. So, thanks to Swarna and Chandrani, and thanks Dr. Roslin. I had to tell
Thank you,
this
ma'am.
story. I had to tell this story. The storytelling is very important. Everybody should learn how to tell a story. Tell it like a story. Don't read it like a book. Yes. When
Yes,
you tell
ma'am.
it like a story, people will remember the story, right? So, this is
Yes,
for
ma'am.
everyone sitting here. Let's learn to share stories that we are getting exposed to, right? So, when you see a WHO update, it's a lot of gyan. When you go from here, you should think, how am I going to use this information in my hospital? Oh, Swarna is a principal. So she's going to think, how am I going to make this very simple for my students so that they understand this is a major part of the medication safety, medication reconciliation, right?
Yes, ma'am.
And beautifully explained like orchestra and all the other things. I really loved all the analogies that you have used to talk about this. And in the end, yeah, healthcare is all about being an orchestra only. Everybody has to play their part. Otherwise, the patient outcomes will not be a Surila outcome. It will be
Yes, ma'am.
Besura outcome. It can become that is all patient harm that is going to happen. So the recording is going to be available. Those who missed it, they can go and literally learn medication reconciliation. So I only want to say, please take away some practical things so that you can go back and do something. Don't think that you have to start with the international reconciliation form. It's very important to be on the ground and say how is my team? How can they manage this very easily? Right? I had spent a lot many hours thinking what form will work because those days no EMR, nothing. Now, those who can afford technology can do everything very easily.
Yes, ma'am.
It will pick up from the chart itself that this was the medicine, this is missed, and if there must be a reason if something is missed. All that thing can be done by technology, but not everybody can afford. So the intention is to understand the importance of reconciliation and practice, and then go back and tell your safety team, your pharmacologist, whoever is responsible to say, can we start doing this process? And
Ma'am, nurse is the main key point because when a patient admits in the hospital, nurse is the first person to meet the patient
and
and take all the information from the patient. She
people
has to.
also to see. Okay, I think it's safe.
Right. Thank you, Chandrani, and
Roslyn, please wrap it up.
Swarnalata was for that wonderful session. Though we have exceeded time, we have still 100 more participants who are still waiting to hear. That's good.
Thank
So remember the acronyms which he said: collect, compare, and correct. Correcting the correct history. As nurses, we need to collect the complete history, document it, and make sure you compare it and correct it. In case we missed out, make sure we correct it. So all these things can definitely help in the patient safety. That is, omitted need of the patient can be settled, and the wrong dosage can be corrected, duplications can be prevented, and drug interactions can be checked. Thank you so much, Chandrani, for that vast knowledge
Thank
which
you,
you
ma'am.
have shared. That was wonderful. Right. Now, next month, again, we have the safe sessions we have planned for the entire year, and IV medication safety, infusion error prevention will be done by Nagarani next month. So please join us. We will be sharing the template with you. Thank you so much, participants, for being with us. And all our recordings are there. Previous sessions and previous year sessions are available in the YouTube. Please share it with your students. Share it with your novice nurses. That will be so helpful to them. Thank you so much. Thank you, Tangam ma'am, and all the participants.
Thank
Bye.
you. Shabba khair.
Bye.
Thank you,
Thank
ma'am.
you, ma'am.
Thank you all.
Thank you.